Alright, so let's talk about benign skin lesions for a minute. So benign skin lesions are from the name, lesions in the skin that are benign in nature. And there are many, but the ones we're going to be talking about are specific types, more common types that you might see or we will all see at GP. That we want to know these benign skin lesions, what do they look like, so that we are aware of it and that since we're aware of it, we can communicate to the patient as reassurance that this is not a malignant case, it's just a benign case. And a lot of these benign skin lesions are ones that will never turn into malignant. Each of them individually, specifically each one. And they're not malignant, and that's the thing. We want to know the ones that are benign so that we can reassure the patient and at that point not try to misdiagnose the case as well. So let's talk about benign skin lesions, shall we? So regarding benign skin lesions, we said these are ones that are not going to be turning into malignant. They're purely benign. There are some that have bad prognosis despite being benign, and we'll see it like in the case of keloids, but we'll see that later on. So we'll start with the first one, which is known as seborrheic keratosis. A patient, let's say a 45-year-old patient, he may come to you to the clinic complaining of a mole, and he has this mole anywhere in his body. He can have it anywhere in his body, in the hand, in the back of the hands, in the forearm, anywhere in the body. All right. Let's say in the trunk, for example. And let's say you examine this mole and you see this mole. You are not sure, is this a case of melanoma or whatnot? No, if you inspect it very closely, this is probably a case of seborrheic keratosis. So let's look into seborrheic keratosis for a minute, which might appear in the form of a pigmented mole. It could be black, it could be white, or it could be any color, but especially black, especially someone who might see it for the first time, you might think this is melanoma. No, there are certain features we need to know that will distinguish it from cases such as melanoma. So from the name, seborrheic keratosis, one might think this is related to sebum, but this is a misnomer. This is really a false name. This is the old name. Seborrheic keratosis has nothing to do with sebum. It's just that this disease involves growth of the epidermal layer. Your epidermis, the outermost layer of it, the stratum corneum, there is a overgrowth of this area. And because there's overgrowth of this area, there will be a skin lesion. And the skin lesion appears in the form of a pigmented plaque, a raised lesion. And typically, this pigmented plaque is sharply demarcated. So if you look at all of these colors, each of these three, all of them are sharply demarcated pigmented plaque. And what I mean by pigmented is that the lesion that appears in seborrheic keratosis as a result of epidermal growth of the epidermal layer, when there's overgrowth, there will be appearance of a pigmented plaque. And the term pigmented means this plaque, this sharply demarcated plaque, may come in different colors. Some may become black, some may become tan-like, some may become not purple or red. I'm just saying, in black, yes, some of them are black, but some of them come in different colors. Some may come light-colored. They may come in a variety of color, any color you like, but they're typically pigmented, all right? So, in the case of seborrheic keratosis, you may see the presence of sharply demarcated pigmented plaque, like black-colored plaques or anything else, and they're found in all over the body, anywhere in the body, and typically they're multiple, not single, anywhere in the body, multiple, especially in the back or in the trunk. They can be anywhere in the body except PMS. They will not be found in the palm of your hand. They will not be found in the mucosa. They will not be found in the soles of your feet. So, if you're suspecting seborrheic keratosis, but it's on the palm, or it's in the soles of your feet, or it's in the mucosa, then this is not seborrheic keratosis, because you will not find it in these areas, but you can find it anywhere else. You'll find multiple sharply demarcated pigmented plaques, especially all across the body except PMS. You'll find it especially in pictures in the back, in the trunk, or anywhere else, okay? Except PMS. Of course, this epidermal growth, the problem isn't the fact that it's benign. Like, it's benign, it will not turn malignant, all right? That's a good thing. And it's really harmless. However, this thing can be reoccurrent in nature, meaning once you have this plaque appear in your life, it will never disappear. You remove it, it will appear again. You remove it, it will appear again. And that can be bothersome for the patient, especially in terms of cosmetic appearance, right? So we have a recurrent epidermal growth that occurs mostly in adults, right? That mostly occurs in adults, so 40 and above. You really not see it in people that are in my age, 22 years old. You really see it in middle-aged people. And it's typically seen as harmless. It's not really not that bad of a thing. And it's harmless. It's just, it could be irritating to have it appear over and over again. And you remove it, it comes again, Of course, the age group can differ. For example, just because it's harmless, especially among middle-aged people, especially since it's benign, just because it's harmless doesn't mean that every time I see it, oh, khalas, I just have to just do reassurance and khalas. No. You see, let's say we have a patient here who's 45 years old and he has these moles, he has these black moles, right? And he tells you they were multiple and they appeared for around 3 months. Wow, they appeared very, very quickly and they were multiple. Here in this case, I am not suspecting seborrheic keratosis. Seborrheic keratosis, it could be multiple and over a long period of time. But if a patient came to you with presence of black moles and they appear very, very quickly in a very short period of time, here I'm not thinking seborrheic keratosis. Here I'm thinking this might be a sign of malignancy. This could be a sign of maybe GIT cancer, for example, or especially young people. Young people, like in my age, they may come with black mole and they may suspect that this is not seborrheic keratosis, this is a case of nevi, collection of melanocytes. So they might suspect a collection of melanocytes, and if it appears rather quickly, this might be a case of melanoma. So the idea is that even if a patient came to you with black mole, you don't just automatically assume this is seborrheic keratosis, especially if you have a black mole like this one, and it becomes multiple and they appear very, very rapidly, even in a middle-aged person. Here, no, I'm thinking this is not a case of seborrheic keratosis. I'm thinking this might be a sign of internal malignancy. And they gave this a term for seborrheic keratosis. They call this paraneoplastic sign. That is a characteristic thing that's associated with seborrheic keratosis, in which if you see these plaques appear very, very quickly in a short period of time, even in a middle-aged individual, here I am not thinking this might not just be seborrheic keratosis. This might be a case of internal malignancy inside, like GIT cancer or anything else. Okay? Of course, how do I diagnose seborrheic keratosis? Really? Do I diagnose it from the outside? Not really. Any clinical diagnosis can be difficult, especially since one might confuse it with melanoma, especially the black colored ones, right? So if I want to confirm for seborrheic keratosis, I can do two things. One, I could scrap off the plaque. I can scrap off this one or this one or this one. I can scrap it off and I'll see what looks like a stuck-in thing. There's like a structure inside this plaque that resembles a wax. So if I scrap off this plaque here, and here, I'll cut off the superficial layer and I'll see inside it what looks to me like a wax. So I'll see a waxy colored texture that will confirm for me that, okay, this is a case of seborrheic keratosis. And that's what these plaques in seborrheic keratosis consist of. When you scrap it off, you'll see this waxy colored texture. So when I wax this one off, it will show me this waxy colored texture in this plaque, all right, what contains inside it. Another thing I can do to confirm even further, I'll take a device known as a dermatoscope. You can think of it like a microscope for dermatologists. They have a dermatoscope, they put it in the lesion, right? They implant it on the lesion and they will see in their eyes what does this lesion consist of. So I can also use a dermoscopy to look inside this lesion and I'll see the presence of cysts or pseudocysts. They call this keratin pseudocysts. Keratin PC pseudocysts. If you see the presence of white color cysts in the skin lesion, then this will absolutely confirm for you seborrheic keratosis. There's no black spots in this lesion. You'll see white colored pseudocysts or keratin pseudocysts, multiple of them in the skin lesion. When you look inside your microscope with the dermoscope in this lesion, this can also confirm for you seborrheic keratosis, okay? So that's one way also to diagnose it, not just clinically, but also by scrapping this part of the superficial part of the plaque to see the waxy color texture, and also through dermoscopy to look for the presence of keratin pseudocysts in seborrheic keratosis, okay? Now we finish with seborrheic keratosis. What is the treatment for seborrheic keratosis? Well, you can go through a number of treatment. You can do cryotherapy for this patient. You freeze the lesion and you will be sloughed off. You can do cryotherapy. Or you can do curative. You can remove it. You can basically remove it by an incision or whatnot, by a needle or whatever. You do a curettage, you cut it out, and it will leave in its place a pink moist base. Once you remove the plaque, in its place there will be a pink moist base present in the skin, and it's fine. It will fade off after a while. So these are a number of treatments. You can also do electricity. You can basically electrify the lesion as well through something known as light electrodesiccation as well. So there's a number of treatment you could do for seborrheic keratosis. But regardless, either way, it is harmless. It's really done for cosmetic purposes. But we need to be in mind, we need to be aware of history. If a patient came to you with these black moles and you're suspecting seborrheic keratosis, you have to make sure it's not in the palm, it's not in the soles of the feet or in the mucosa, and it's not growing rapidly at a very short duration. In that case, there could be a sign of paraneoplastic sign. You need to make sure this is not a sign of internal malignancy, all right? This might be a malignancy that's causing this, and not seborrheic keratosis itself, which is caused due to overgrowth of the epidermis, or overgrowth of the cornea layer, okay? That's pretty much it that's seen in adults typically, seborrheic keratosis. Now that we finished seborrheic keratosis, let's talk about a variant of seborrheic keratosis, another type. A variant of seborrheic keratosis is dermatosis papulosa nigra. From the name, we have the presence in this patient's face, we have the presence of multiple small hyperpigmented papules all over the cheeks and also in the temporal area. So if a patient comes to you and he asks you, doctor, are these freckles? No. You inspect closely and you'll see the presence of multiple small hyperpigmented macules all over the cheeks as well as in the temporal area. There you can diagnose this case clinically as a case of dermatosis, meaning skin disease, papulosa, papule, nigra meaning black. So you diagnose it as a case of dermatosis papulosa nigra, which is a variant of seborrheic keratosis. It's a variant of SK. Okay? Of course, what is the treatment for dermatosis papulosa nigra? Again, it is very harmless. It's just benign. It will never be malignant. The treatment is cosmetic. You can do for this patient light electrodesiccation. Basically, you will destruct this lesion via electric current. You will destruct it and it can be removed. However, will we do chirotherapy for this one? No. Chirotherapy can be given as an option in cases of seborrheic keratosis. But in this variant type of seborrheic keratosis, in this dermatosis papulosa nigra, you will not give this patient chirotherapy, because if you freeze the lesion, it will cause dyspigmentation. Basically, the color, it will stay as it is, and it will become even worse. It will become even apparent, and it will make treatment even more complicated as it is. So chirotherapy, if you're thinking of freezing as an option, do not do it for dermatosis papulosa nigra. But you can think of it as an option in remaining skin lesions, especially one such as seborrheic keratosis. Okay? Now we finish seborrheic keratosis and its variant. That's pretty much it. Again, both of these are really asymptomatic. Patient will not complain of anything. Maybe itching at times, but really it's rare. Patient just typically comes with asymptomatic case, and it's just typically bothersome. It's really cosmetically disfiguring for some patients. Okay? Now let's go to the next benign skin lesion, and that is skin tags. Now skin tag is another benign skin lesion in which you can think of it as a grass. There is a grass that is growing, or let's say a flower that is growing in the skin. You see, in the case of skin tags, they like to grow in areas where there is friction with the hair follicles. Like, let's say the ones in the groin region, or the ones in your axilla, or the ones in your buttock. They like to grow in areas where there's friction. And typically what's happening in skin tags, which is another name for acrocordons, we see what's happening is that you're going to have a presence of an overgrowth, right? You have an overgrowth in the skin, and this overgrowth will lead to the appearance of what looks like a flower, let's say, or like a plant. This will lead to the appearance of these brownish colored things. These brownish colored things you see, let's say in the forearm of an individual, or his axilla, for example, these brownish colored things represent brown colored to skin colored, or they sometimes call it fleshy colored, but they can be brown colored, pedunculated papules. Pedunculated means it's like a beanstalk. Like a beanstalk, like this one right here. So you can see this beanstalk right here, or this pedunculated papule lesion. And that's what you'll see in skin tags. Patient may come to you complaining of maybe a mole. You inspect the patient's forearm or his axilla. Oh, you'll see the presence of these skin tags, which appear as brown colored, hence the color brown colored, or sometimes skin colored or fleshy colored pedunculated papules, okay? And typically the cause for skin tags, again, they're harmless, but the cause for skin tags is not exact, but their association with certain things. There's association with certain things. Skin tags, for example, one of the causes could be F, which was mentioned before, friction. Like in areas of skin that are prone to friction, like the axilla, like the groin, like the back, or the buttocks. But areas that are prone to friction that can lead to the development of skin tags, right? Another cause could be obesity. You can see this especially on obese individuals and especially in people with type 2 diabetes where they have insulin resistance. So you can see this especially in people with obese, people with type 2 diabetes where you can see the appearance of skin tags. Again, the cause is really unknown as to why that is the case. Another one, we finished with O and D. D stands for diabetes. The O stands for obesity. Another cause could be genetics, G. G could be genetic. It could be a genetic acquirement of skin tags. And also the last one is the P. P could be seen in pregnant individuals. You might see a pregnant lady, she might come with the development of skin tags. However, following pregnancy, it might disappear as well. Again, the cause is unknown, but it might be related to hormones in pregnancy, okay? So the cause is not exact, but is associated with a number of conditions. O, obesity, G, genetics, F, friction, P, pregnancy, and D related to diabetes, type 2 diabetes, as a marker of insulin resistance, okay? Now what about the treatment for skin tags? Again, they're harmless, but they can be removed. In the case of skin tags, some of them may not have to be removed necessarily because a lot of the pedunculated papules, some of them may grow bigger, and they might grow to the point that they might obstruct their own blood supply, meaning that each skin tag has their own blood supply. So when they grow bigger, they might obstruct their own blood supply, or they might twist. They might form a twist, or they twist one another, or they twist against each other. And when they're twisted, you can basically think of it as strangulation. And strangulation to what? Strangulation to their blood supply. So you might see the color become black as a sign of necrosis, and eventually they might slough off. So a patient could just wait, and maybe in some skin tags, they may become twisted and obstruct their own blood supply and become necrotic. But in most cases, patient just comes to you to remove it for cosmetic purposes. So in regards to the treatment of skin tags, it's the same as seborrheic keratosis. You can do for this patient chirotherapy, it's fine. You can also do for this patient curettage if you want, if you just want to remove it, it's fine. So typically for this one, chirotherapy is more preferable in most cases, okay? For some people, in skin tags, okay? Let's be regarding skin tags. Now let's go to the next one. The next one is cherry angioma. The patient may come to you with a 6 months history of a red mole. And this red mole will be in this drawing in the trunk, in the upper trunk, most commonly. So if you see in this patient presence of multiple red moles all over the upper chest, and you go with his history that he has this red mole for the past 6 months, and let's say in an adult case, then this is a case of cherry angioma. From the name, you have an abnormal blood vessel that proliferated, and really this is similar to previous video when we talked about vascular lesions in pediatric. But the difference is this one is acquired, This one is typically acquired vascular proliferation for whatever reason, and this occurs in adults rather than in children. So you'll see the presence of this vascular proliferation region known as cherry angioma seen as multiple types, multiple ones, all over the upper trunk, all right? And from the name, they appear as a cherry. Now the thing about cherry angioma is that some of them may become necrotic for whatever reason. Some of them, their blood supply may become obstructed, and some of them may become necrotic for whatever reason. Maybe their blood supply is blocked or obstructed. Maybe there's a thrombus or whatever. And when they become thrombosed and become necrotic, the color of these red moles may become black. So a patient may come to you in a late case. Maybe he comes to you with a black mole. And somebody might mistake this for melanoma, but this is not the case, because typically what you do in cherry angioma, if you suspect cherry angioma, what you do, if there's a black mole, you take good history. You always have to take good history regardless. So a patient may come to you and he tells you, I have a black mole. So you take history and he tells you, oh yes, at the beginning it was reddish in color, doctor, and there were multiple. So no, in that case, you can exclude melanoma. You can say this is a case of cherry angioma. It's just sometimes it's mistaken for a melanoma when one of these lesions, their blood supply is obstructed by a thrombus. So they can appear black due to necrosis. But originally, with history, you'll say that the patient told me there was history of multiple red moles all over his upper trunk. I can rest assured this is cherry angioma. Now, regarding the treatment for cherry angioma, again, once I diagnose it clinically, I can diagnose it with my eyes. The treatment is really cosmetic. I could do laser for this patient since it's a vascular lesion. Any vascular lesion in the skin, I can think of laser. So I can use a laser known as a dye laser from previous video. I can use a pulse dye laser and I can ulcerate the lesion. I can remove it. Or I can also do chirotherapy if I want. Alright? That's pretty much it for cherry angioma. The next one is keloid. Now keloid, it is benign. It will not turn malignant, but it is a serious condition. It is a condition in which you have to be very aware of, especially in the mind of a surgeon. You see, keloid, it is a benign skin lesion in which there is overgrowth of the scar tissue. You see, typically whenever there's damage to your skin, typically the skin can regenerate itself. But if there's too much damage to the skin, especially deep, it will lead to the development of a scar. That's part of the wound healing process. And the thing that contributes to the scar, or the thing that contributes to wound healing, are your fibroblasts. Your fibroblasts is like to secrete collagen to contribute to scar tissue development. But let's say there is an overgrowth of fibroblasts. There's too many fibroblasts, they're producing too many scar tissue. Well, in that case, this will lead to the development of keloid, which is an overgrowth of scar tissue unnecessarily. So a patient may come to you that he has a firm growth in his earlobe right here. He had a history of ear piercing, or he did a surgery from before in his chest, and then he came to you with presence of multiple growths in his sternum, for example. You look at it and you'll say, this is a case of keloid, definitely. And the cause of keloid is not exact, but the cause is really genetic. It's family history. So typically a patient with keloid, he'll tell you that, oh yes, somebody in my family had the same problem. When they did surgery, following surgery, they had the presence of these growths. So keloid is typically involving genetics here. There's family history of keloids, especially among black people or African Americans. African Americans are the most common really race. They may present with keloids, especially family history. That doesn't mean African Americans are the only one. It could be in anyone, but African Americans are the most prevalent, especially with family history, where they come with a firm growth, whether in the earlobe, one common site of keloid, or in the sternum, most commonly. Alright? So that is the thing with keloid. And the thing about keloid is that somebody might think, oh, I can just remove it and that's it. No, unfortunately you cannot. You see, the thing is, with keloid, with overgrowth of the scar tissue due to genetic reasons, the problem with it is that if you were to remove it, it comes again. You remove it, it comes again, and again, and again, and again. So it's recurrent. You remove it, it will come again. And that's why it's really a problem. It's really bad prognosis with keloid, especially in surgery. Because the thing with keloid, they're very ugly. You see it, it's very ugly, and it's very noticeable. So a patient might say, I just wanted to remove it for cosmetic purposes. But if you remove it, it will come again. That's why surgeons, they have to ask patients before any surgery, and not just any surgery, surgery that is not elective, surgery that is necessary. Before any surgery, they have to ask them, do you have a family history of keloids? If they do, they have to keep this in mind that, okay, this surgery I'm about to do, is it necessary? Is it an elective surgery, or is it a surgery that I have to do? I have to see whether the benefits outweigh the risks, alright? Because in this case, in keloid, the surgery is elective. In that case, the surgeon or the dermatologist, he'll just tell the patient, no, it is in my experience, or from my advice, I will not remove the keloid, alright? If I remove it, it will come again, alright? Because it's not necessary. This is an elective procedure. It's not necessary to remove the keloid. We can leave it as B. So I will not do surgery for your keloid unless you're undergoing, for example, a big surgery. Let's say you're going under surgery for necrotizing fasciitis, for example, or in the form of debridement, or you go in cardiac surgery, or any major surgery, then no, the benefits will outweigh the risks. You'll do it, and of course keloid will appear, but again, the benefits will outweigh the risks. Or if the keloid itself, the lesion itself, the growth itself, it may come itchy. If it's itchy or tender, if it's painful, then okay, the benefits will outweigh the risk. Then I can do surgery. So it's surgery if needed, okay? And if I'm not going to do surgery, one thing I can also do as well, besides reassure the patient, is I can also give this patient as drug of choice intralesional steroid. I can directly inject inside the keloid intralesional steroid, like for example triamcinolone, one of these potent steroids. And again, intralesional steroids is not exclusive to keloid. You'll also find this in cases of, for example, you find this in cases of people with infantile hemangioma, certain babies with infantile hemangioma, or in people with contact dermatitis, for example. So it's not exclusive, the intralesional method, but this is one of the indications for intralesional steroids is in the case of keloids. So you can do this as well. But typically, in most cases with treatment, is really, you have to tell the patient's reassurance, unless the keloid bothers you in the form of itching, or in the form of tenderness, or you have to undergo a major surgery. So elective surgery is a no-no in such cases, okay? Because it's recurrent, again. Now the keloid is, again, like we said, it appears as a fibrovascular growth. You'll find most pictures, just find any picture. You'll find a growth in the earlobe or in the back of the earlobe, or you can find it in case of the sternum, okay? So that's pretty much it from the keloids, alright? So that's for the keloids. Now the next one we're going to be talking about, and the last one is milia. Now milia can be found, it can be found in anyone. It can be found in children, and it can be found in adults. And what is milia exactly? It is a tiny epidermoid cyst. A patient may come to you, and he may complain of really a white spot. There's like a white spot in his cheek or in his forehead. You look at it, and you'll see this this tiny little cyst. This cyst that appears whitish in color or yellowish in color. You inspect it closely, and you'll see, this is a case of milia. Milia, which is a tiny epidermoid cyst, meaning a cyst that's basically under the epidermis, or basically right in the epidermis layer. And this cyst basically consists of a sac that consists of milia, a substance known as milia. And if you want to give it a dermatological description, basically what appears as clinical presentation is a patient comes to you with very small, tiny little fixed, whitish to yellowish papules, alright? Yellow to whitish papules. Of course, somebody might say this is lipoma from observation, but no, this is not lipoma. In the case of lipoma, you have a mass, you have a lesion or a mass consisting of adipocytes that are covered by the skin. But in the case of milia, when you look at pictures, you'll see that the cyst is outside. It's outside, it's not covered by skin, alright? So you'll have these tiny little cysts that are within the epidermal layer consisting of milia, or if you want to go by description in dermatology, you'll see the presence of multiple small, fixed, whitish to yellowish papules, okay? That is the characteristic features of milia, and this is diagnostic clinically. You do clinical diagnosis, okay? Of course, in the case of milia, this is a good and a bad thing, alright? And it depends on the age group. I mentioned that milia appears in both adults and children. It can appear in anyone. In the case of infants, this is a good thing. Milia is very, very common in infants. You might see a child who is born with multiple milias all over the cheeks. So the parents come to you, tell you, this baby has this thing, he has this milia. Do we have to do surgery? You'll say as a doctor, no. Milia is a very, very benign thing that can resolve itself. You see, milia is very common in infants, and it can resolve itself after a couple of weeks, alright? You don't have to do anything, just reassurance. R for reassurance. But what about in adults? In adults, no, it's a bad thing, because the milia in adults, it's recurrent, it's persistent. In most cases, it is persistent and recurrent. So you can't just do reassurance and that's it. And the thing about milia, it's harmless, but the problem is it can be bad for cosmetic purposes. So in the case of an adult individual with milia, let's say a 30-year-old, here you'll not just tell the patients, oh, reassurance, and it will disappear on its own. No, it will not disappear on its own. Here you can do a treatment for this patient. And the treatment for milia among adults is E. You can do what is known as excision. You can basically remove the milia itself. You can basically use a needle for example, or a laser or anything. You can use something to cut out the cyst itself. You can use anything. You can use a curettage, for example. Anything to remove the cyst, remove its contents, and alas, you remove it from the cheek. So you can just remove it through curettage. Remove the cyst itself or the lesion itself, and it will not come again. But if you leave it on its own, it will not disappear. Okay? So here you can remove it and it's safe, and it's not like keloid where if you remove it, it will come again. That's not the case in milia. But if you leave milia alone, it will not resolve on its own. In the case of adults, in infants, yes, it will resolve on its own. Okay? That's pretty much it for the milia. And something might ask me, will there be a scar if I remove the lesion here in adults? If I remove the milia, will there be a scar when I treat it? No. There will be no scar when you remove the milia during surgeries, during a simple curative surgery among adults. So overall, it's a good thing, and especially for cosmetic purposes among adults in the case of milia. Okay? So that's pretty much it for the benign skin lesions, all of them. We talked about seborrheic keratosis, dermatosis papilosa nigra, skin tags, Sherry angioma, keloid, and finally the milia. Okay? Thank you.